And with this, we move forward to the next presentation coming from Dr. Horst Sievert, who's a renowned figure globally. He's based out of Frankfurt in Germany, holds the CSI conference on structural interventions globally, and he's a great friend of Cardiovascular Therapeutics India, and we are always lucky to have him in our meetings. So over to you, Horst, and I think right now you're traveling to Georgia, as you had mentioned to me. We'll see this exotic carotid stenting case, which you're going to show us now.
Thank you very much for the invitation. Actually, the trip to Georgia has been canceled because the devices did not arrive due to corona-related issues. So I'm still here in Frankfurt. So these are my disclosures. This is a case which was really a big disaster for me, but fortunately a great save for the patient, as you will see. So the subtitle of this lecture could be, could you please bring me a glass of orange juice? And I will explain later why this could be the subtitle of this. So this is the history of that patient, a female patient, 78 years old, symptoms, pain in the right shoulder, paresthesia of the right hand, vertigo and dizziness, and blood pressure was 81/56 on the right side and 113/68 on the left side. And duplex showed no stenosis, but a retrograde flow in the right common and internal carotid artery, and a retrograde flow in both ophthalmic arteries. So the diagnosis is clear from here. It's basically an occlusion of the brachycephalic trunk. It was an aortic arch type 2 or 3, osteostenosis of the left common carotid artery, and a 2 centimeter long occlusion of the brachycephalic trunk, as you can see in this not very good image of the MRI angiogram. So she was scheduled as a live case during our carotid stenting conference, ICCA, but we were running out of time. So fortunately, this case was continued offline after the end of the live transmission. So we choose to go for a radial and femoral access. Again, you see type 3 aortic arch, a calcified occlusion of the brachycephalic trunk, and an osteostenosis of the left common carotid artery. And maybe one of you can comment how to proceed from here. Is Klaus still there? Or who else would like to comment?
Yeah, Klaus, would you like to make a comment?
Yes, I can give a comment. So I would recanalize the innominate artery from the arm.
Okay, that's what we did. So we recanalized by the radial axis, and then we installed a wire rail from the brachial to the femoral artery, but then the balloon was introduced from below. And then we did balloon angioplasty first. And this is an 8 millimeter stent, and this was the final result. Any comments here? If not, then I proceed.
Looks fine, yes.
Distal ledge of the stent has something.
There's a little bit narrowing at the proximal end of the stent, but overall the result looks pretty good, I thought, but the patient was unfortunately unconscious.
So stent was delivered.
Have you considered protecting this lesion? Because
No.
our experience with brachiocephalic trunk with very recent lesion is that we should, as possible, protect the internal carotid.
How would you protect?
Because the risk of embolization is, in my opinion, high. I think the selection of a stent you had, Horst, was, first of all, good evening. And second, I think the selection of a stent you had was excellent, because I think it's really the territory of a balloon expandable stent, because usually these brachiocephalic trunk are around 8 to 10 millimeter, and you have to enlarge them. But I think when possible, you have always to consider protection of the internal carotid.
How to do this, Max? How to do?
What Klaus has said, which is starting from the arm, opening slightly this artery to avoid any distal embolization, and take the chance with the channel that you have open, really to place a protecting device, and after follow the case.
So coming from femoral, okay, that would have been an option after crossing the lesion, I agree. But we did not do this in this case. So we did intracerebral angiography, and we saw slow flow in all cerebral branches and multiple occlusions in the anterior cerebral artery and multiple peripheral branches of the middle cerebral artery. So what to do now? Short answer, please, because we are running out of time. Max, short answer, what to do now?
Claus in Sasco, would you like to take that? Or?
Yes, first, I would be interested, what is the blood pressure of the patient, yes, at that time, yes, because when that dropped too much, then it's possible that that is one of the causes. The other is, yes.
Elevated blood pressure is a good suggestion. What else?
What I see here is missing is the anterior cerebral, so I don't know what is coming from the left side because there was an occlusion, so it's possible that now it is supplied from the left side. But that all is not a cause for loss of consciousness. Yeah, so the question is also what is going on in the posterior circulation, because when you recanalize the subclavian artery, you have also to think of the vertebral artery and the posterior circulation. So I would also like to have an angiogram if there is a problem, embolic problem in the posterior circulation, especially the basilar artery.
Okay, so do additional angiograms of other vessels. Okay. Any other subject? A short answer, please. Otherwise, we are running out of time.
I'd like to look at sugar and whether the patient is hypoglycemic.
Okay, I don't remember that, but could be. Yeah. But I thought these
ACT.
I thought these are multiple small embolisms.
ACT. What was the ACT around?
Oh, I don't remember that. It's quite a long time ago. Okay. But good point. Check ACT. Yeah. So you see here, I think here you can see multiple small occlusions.
Because it is diffuse thrombolysis here.
We consider thrombolysis.
Yeah. So what we did, actually we went into some of these branches and we found really small particles there. It's not very visible here, but then we introduced microcatheters and went there and did selective catheterization of multiple branches, local infusion of lytics and 2B3A inhibitors. At that time, for sure, ACT was checked and it was normal, so patient was under heparin. And we tried to open as many vessels as possible and had some success with that. So the outcome, it was a 5-hour procedure and 400 cc of contrast, and some small branches reopened, but still slow flow overall. I missed the social dinner of our conference and the patient did not wake up. And at 2 a.m. I gave up and the patient was transferred to the ICU. Still unconscious at that time. So next morning at 7 a.m. I got a call, Dr. Sievert, you should better come to the ICU. And so I went down to the ICU, and on my way I thought cerebral bleed, respiratory failure due to brain edema, she may be already dead. The family wants to have some explanation. The lawyers are waiting for me. So I entered her room, and very sad that I did not take a photograph at that time. The patient was sitting in a chair having breakfast. And she said, Dr. Sievert, could you please bring me a glass of orange juice? That's where the subtitle of this presentation came from. The staff members of the ICU were very sad that they did not take a picture of my photo and my face. This was the outcome. MRI showed not more than multiple small embolic lesions. And 4 months later, patient has recurrent symptoms, high-grade restenosis at the ostium, as you see here. We crossed with the wire. Catheter could not be advanced at that time. And then another wire loop, like in the initial procedure. Long sheath placed via femoral access. And now comes back to the comment of Max, embolic protection. How to do embolic protection in this situation? And what we did is actually manual compression of the right common carotid artery during balloon inflation. So this shows you balloon angioplasty, and then the second stent was implanted. And third stent implanted in the right subclavian artery, which also had a stenosis, and this was the final result without any pressure gradient and no complications. So take-home messages: embolic protection is difficult in brachycephalic angioplasty. Manual compression of the common carotid artery during balloon inflation is an alternative. And the shower of emboli is one of the worst complications of supraortic vessel interventions. Have microcatheters, lytics, and 2B3A inhibitors available, and of course a glass of orange juice. Thank you much for your attention.
Thank you very much, Horst. That's very interesting. So what does one do now? Max made a point about using a embolic protection. One way of doing it is compressing the common carotid from outside, but you're not always very confident to compress a diseased vessel. So how would some of our experts go about it? Klaus and then Vimal Someshwar.
Yes, I think it was important to use thrombolytic agents, and when these are very peripheral lesions, yes, and sometimes the lytics are very effective. We have the problem that more central arteries like the M1 segment of the middle cerebral artery or the carotid artery or the basilar arteries, these are large thrombi with a length of 6, 7, 8 millimeters. So there you need too much time to get that thrombolized. But with these tiny particles, as far as these are thrombus and not other atherosclerotic materials, yes, I would perform a thrombolysis.
How do you dose the lytics, Klaus? What dose?
Yes, with 2B3A inhibitors, I would go up to, yes, 70, 80 milligrams. Yes.
Interesting. So what we do in this situation, I mean, it doesn't happen every day, but if it happens, then we give very low dose. It's actually like what we use in peripheral angioplasty. Sometimes it's about 1 or maybe 2 milligrams per hour as a continuous infusion via the guiding catheter. So that means the total dose is very small. And if any bleeding occurs and we stop, then the effect is stopped immediately. So that's our technique for this particular situation.
So you did
regarding embolic protection, I mean, one option would have been, of course, to use a filter coming from the arm. But then we either need a bigger sheath in the radial artery, or we would have to give up the arterial loop, which goes from the radial artery to the femoral artery. But the advantage compared to the technique from Marx would be that we could have some protection before we cross the occlusion. Because even at that time, of course, emboli can occur when we cross the occlusion, not only during balloon angioplasty and stenting.
If you allow me a comment,
yes, Max.
Horst, I think for the arm, the problem is trapping the filter with a stent. So really, after the retrieval, could be extremely difficult.
Yeah.
So I think the people that attempted it are people that, for example, have used the old percusseur balloon, that is easier through the stent. Otherwise, I think not recommend going from the arm to place a system, and because you have a lot of difficulties really precisely placing the stent. I think this is why I think predilatation, opening a channel, placing an introducer, a large introducer or large guiding catheter, and placing a protecting device in order to be able together to have the filter inside of the guiding catheter of the introducer and the stent deployed. So you have both parallel, and after you are able, not completely deploying the stent to be sure that you are able to retrieve the filter and after finish the procedure. So it's not in any way what you did was excellent, because it's an extremely difficult case. It's not a debutant case, for sure. It's not a debutant. So you pay a price to an extremely difficult case.
The people who do more complex work are more likely to face with these challenges. There's no doubt about it. And the takeaway message from here is that even if you have a huge complication at your hand, if you have a glass of orange juice in the pantry, and then you're probably going to come out of it. Thank you so much, Horst. And
Very
with
much.
this, great case, and we'll remember it for a long time.
Bravo.
Let's move to the next presentation by Dr. Bimal Someshwar, intra-procedural stroke. So another case of a similar type. Let's see how Bimal carries it on. And there you go, Bimal.
So, yeah, can I start? Yeah.
Yes, please.
Okay, so first of all, I want to tell you that this is a case which was done with my colleague, Dr. Manish Srivastav and Gordon, who are neurointerventionists, my other junior colleague, and myself. And I'm sure there'll be a lot of questions with this particular presentation. Can you go forward? Yeah. So this is a 84-year-old lady, hypertensive, has diabetes, ischemic heart disease, and has undergone CABG in the past. Recent history of 2 episodes of syncopal attack. And can we get this off from here? With unconsciousness. At this stage, no neurological deficit. In the past history, there is a similar episode of syncope and loss of consciousness 2 years ago. And at that time, she was worked up, Holter monitors showed VPCs and was started on beta blocker. This was in 2017. The 2017 MRI showed 60% stenosis of the right carotid and left carotid about 50%, with moderate bilateral supraclinoid stenosis. So this patient was put on dual antiplatelet at that stage and beta blocker, as I've mentioned, with the rest of the medication that she was taking. Still not going forward. Yeah. At present, the syncopal episode had at this time all the investigation normal, electrolyte and all the blood parameters were normal. The cardiac workup was normal. EEG was also normal because we thought this could be an epileptic attack, but it was ruled out. Patient was on antihypertensive, anti-diabetic, beta blockers and statin, and was already on dual antiplatelet. The MRI at this stage in 2019 December, as you can see that on 24th December we have done this. There is just chronic ischemic changes in the brain with preventricular and deep cerebral white matter. There was no acute infarct at any point of time. So all these were just some old ischemic spots. The carotid angiogram with contrast showed stenosis, near total occlusion of the right internal carotid artery at the ostium. And if you look at the left side, there is about 60 to 70% stenosis. So this is a bilateral carotid artery stenosis that we are seeing it, right more than left. Now, if you look at the arch, which was normal, and the innominate and the carotid origin, the left subclavian was all normal. Our question was, should we treat this syncopal attack with bilateral carotid artery stenosis? And we went through literature and we found one paper where they have shown that there is a reduced blood flow to the brain in bilateral internal carotid artery stenosis. And this possible mechanism of syncopal attack will be better if you revascularize it. So in this case, they had done a surgical revascularization, and we thought, yes, bilateral carotid artery could be opened up and could take care of the syncopal attack. This is the test that I was talking about, sorry. The impaired dynamic cerebral autoregulation in carotid artery stenosis, and it showed that the carotid artery which was stenosed has a slow flow as compared to the normal carotid artery, and therefore opening up this would definitely help improve the flow and may help improve the syncopal attack. With that background, we first went in with the idea of opening up the right carotid artery. As you can see, it was much tighter lesion. Also, it is important to show that there is marginal stenosis of the supraclinoid IC on the right side. If you look at the left side, there is about 60% stenosis here, and again, supraclinoid carotid artery stenosis. So with that background, we did the vertebral artery again, 4-vessel cerebral, and you can see that bilateral vertebral arteries are also stenosed. And at this stage, we thought of doing the right carotid artery angioplasty and stenting using a standard method that we are using. And I would like to introduce a Neuron Max catheter that we are using, which is more, my neuro interventionists are more familiar. This is a brilliant catheter, easy to manipulate, and it can does not require much force to put in. And we go in with the catheter, and then a Neuromax just tracks over it. We use a spider device to use as a filter, and we often use a carotid wall stent here. So this is a classical case where standard right carotid stenting done with improved circulation in the brain. There is a slight stenosis which is there in the supraclinoid. We should not forget that. After 4 days of the right carotid stenting, we went for the left carotid stenting, and you can see that there is a lesion here, and there is a tight stenosis in the supraclinoid IC, as you can see in the AP view, much more prominent than on the lateral view. And in this case, we went in again with the same standard. You can see the Neuron Max catheter with the radio-opaque marker there. And we are trying to get the filter across the curve. And you can see that we are finding it a little difficult to push the filter, which we managed to get it across and was deployed over there. This is a roadmap which shows we straight away went in with the wall stent here, as you can see that. And we deployed the wall stent here without any problem. We did not pre-dilate and did not post-dilate, but immediately after placement of the wall stent, you can see a thrombus. This is the filter here, and this is a stent here. There's a sharp curve which is there, probably shift of the curve which has happened because of the wall stent sitting there. And now the question was how to get rid of this particular thrombus. So we thought of getting the Neuron Max up there rather than using the filter retriever catheter. We managed to get the Neuron Max catheter up there. We could not go past the narrowing or the curve there at the distal end of the stent. And we then tried to manipulate the filter to come down with the thrombus with it. So we wanted to capture the thrombus within the filter. And as you can see that with some difficulty, we did manage to get the filter into the Neuron Max catheter. So you will see that now, that will happen now on the video. There's a condition there. And finally, the filter came down. And when we made the contrast injection, well, the whole of the carotid is occluded. At this stage, since my colleagues are very good with neurointerventions, they went in with the management of acute stroke, same philosophy here. We took a 21 headway catheter and a Traxxas wire. When you made the injection up in the supraclinoid ICA, we realized that the narrowing in the supraclinoid ICA was some help, and the thrombus got stuck in this particular segment here. And when we went beyond and looked at the intracranial circulation, there was no embolus distally. So everything was sitting here at the site where there was a carotid stenosis. And we went in with the stent retrieval device, the Trevo 6x24 into a headway catheter. And as you can see that we opened up the retriever device, and which helped us to retrieve this particular thrombus out. And when after this, we did the angiogram, and you can see that the whole vessel is open, no distal embolus there, even on the intracranial segment. So probably this particular stenotic segment helped us to trap the thrombus here, which could be retrieved with a retriever device. And you can see the AP and lateral view there, they have opened up. Now in this patient, there was no neurological deficit post-procedure. The NIHS score was 0. Patient is kept on antiplatelet. We did not start any anticoagulant in this patient. Next, can you see that? This is a follow-up after 9 months. Patient is stable, imaging not done, no syncopal episodes in the interval period, and patient is still on dual antiplatelet. I will take the questions and further discussion.
That was an excellent salvage done by you and your team. Comments from our experts. Dr. C.N. Makle, would you like to make a quick comment on this? You've seen this case.
Well, it was a wonderful case, and I can understand the adrenaline level at that time in the cath lab. I personally feel it is
Yes.
a mechanistic issue, because while we are going through the intraosseous segment, which was very tortuous and which had you had a difficulty in passing the filter distally. So whether at that particular time, whether the filter itself has injured the carotid intima, and while you are trying to pull back the filter, by the sheer stress, sheer push of the catheter, that has possibly damaged and that has caused the thrombus. However, I'd like to know what was the ACT by any chance, or how much heparin she was loaded.
Yeah, Vimal?
Heparin that we give. Sorry, we give 5,000 units of heparin during the whole procedure.
Any more comments? Dr. Ranjan Shetty and Dr. Tarun Madan.
Sir, I think it was a very nicely performed case. I agree with Dr. Vimal, sir. It was a distal stenosis which helped trap this thrombus, and this was not a dissection in the ICA as is seen in the last picture of the angiogram, completion angiogram. There is no dissection. There is very pristine, brisk flow in the distal part of the internal carotid artery. It was a thrombus which got formed, I think, because of the wire bias or some collapse of the artery which would have taken place, because there was a very less landing zone between the distal part of the stent and the filter.
Yes.
Probably that is where the artery got twisted and the thrombus formation happened. Like
Kink, that was a kink produced.
Yeah, that's what exactly I was saying. It was a mechanistic problem rather than the rheological problem.
Yeah.
Very right. Dr. Tarun Grover, would you like to make a comment over here?
Only thing is, I was wondering that the stent was slightly more higher up, because because of the higher position of the stent, because the lesion was a small lesion close to the bifurcation. If you would have opted for a stent not going as far up, it would have caused a little less kink, and the retrieval of filter and probably the flow dynamics would have been a little better. Just a suggestion, but sometimes you can't anticipate how these vessels behave after you put the stent.
I absolutely agree with you, Tarun. So I think this is probably the stent was a little longer, and carotid wall stent is little rigid, so you can get these kind of shifts.
Straightening of the vessels. Klaus Matthias, would you?
Can we ask a question, Dr. Mathur, with your permission?
Yes, please. Go ahead, Ajay.
Yeah, Dr. Vimal, lovely case, absolutely fabulous. I was just wondering, could we have attempted aspiration of the thrombus? You had a filter in place, and we had a large thrombus proximal to it. Although the stent was long and mechanistic issue, why the thrombus formed is another open question. Could we have attempted aspiration? I was wondering.
So, we were trying to get the neuron max up, but at the curve, we just could not go beyond the curve with the neuron max. So that's the reason we could not aspirate here. Though we constantly, during this whole procedure, on the neuron max, aspiration was maintained with the penumbra device. But we did not get beyond that.
So, while we take a comment from Vipul, and I also request you to start sharing your presentation. Vipul, you make the comment.
I'll just make a short comment. So we had one such case in acute stroke setting, carotid stenosis, acute stroke with a floating thrombus. So Vimal, what we did was, like in your case, what you could have done is another puncture, take another catheter and take an aspiration catheters, which are very soft. Let the filter be there, and that would have sucked out the clot, because when you're trying to take the filter across that band into the catheter, it can embolize. So this is what we did in that case. We made another puncture, let the filter be through the catheter, and took a regular, our brain aspiration, which are very soft, which would have sucked the clot. And then only retrieve the filter when we know clot is gone. But again, in an emergency situation, it's
a lot of things to come to your mind
later on. Yeah.
Excellent. So while Klaus makes a last comment, Vipul, can you please share your presentation?
I'm doing that.
Yeah. Klaus, are you
yes,
there with us?
I think it was well done. I think the stent was too long. I would have chosen a shorter one. But the thrombus, yes, was recovered. So that is the aim of the treatment. And so I congratulate the interventionalist that he got the clot out. Naturally, the other option is to use some aspiration device to get it out, but it followed also in that manner with filter and with stent retriever. That is the other option. So you can that depends also what is your personal experience with one or the other device and what is on your shelf, what is available immediately. Yes, and you can use both devices, stent retriever and aspiration catheter. Yes, you can even block the common carotid arteries and create an under pressure when you want to get the clot out. So there's several options, and at the end, we have seen the option chosen worked well.
Thank you.
Thank you very much. This was an excellent learning case. Thank you, Vimal. And we'll move to Vipul for his interesting case. And again,
thank you, Atul. So I'll just make a short, short presentation about a very unique complication which we had. So I'll just go back 1 second. So it was 65-year-old male, hypertensive, and for 25 years, heavy smoker, and had recurrent TIAs in the right middle cerebral artery territory. And this, I will skip over the basic initial imaging. And this is the main issue which he had, was a very severe right carotid artery stenosis. As you can see, the left artery is already missing there. And this is the intracranial angiogram of right annular carotid artery. By and large, accelerated system, some flow to the ACA, but you can see in the vertebral artery injection, most of the flow on the left side is through the posterior communicating artery, and there was some flow towards the right side as well through the posterior communicating artery. I'm a dedicated neurointerventionist, so we always study the intracranial circulation and dynamics a little bit more intently and do a DSA. So the procedure was pretty straightforward, standard approach. You know, we use a filter device and exact stent, and no issues. And patient did immediate post-op, patient was pretty fine. Now what happens after 24 hours, patient has severe headache as well as visual loss. And what you can see in this picture, you know, he had this vascular congestion in the eye. And of course, one may discuss that what are the common causes maybe it's a carotid artery dissection, embolism, some cerebral embolism, occipital infarctions, hemorrhage, or raised intraocular pressure. So this is the first case which I had seen of blindness. So, and we could see this congestion there, and we were anticipating some cerebral hyperperfusion as well. You know, at this stage, any comments? I mean, okay, we'll just. Atul, I can't hear.
Have you checked that the filter is really well opposed to the arterial wall? Oh yes, it looks in the good. Yes,
fine. As I said,
because that is important. Otherwise, the filter is not filtering everything.
Yeah.
And when you have emboli going to the ophthalmic artery, then the patient suddenly is blind. When these particles are thrombus, then you can do a lysis. We have done that with our ophthalmology department in several cases, where we went up with a microcatheter into the ophthalmic artery and lysed the thrombus. But here, yes, that looks differently. So, because when you have an occluded artery there, then I would expect that you don't see all these tiny arteries as well as we see it on this picture. So I would like to have an angiogram of the distal carotid and see what is going on there.
So anyway,
Horst Sievert, would you like to make a comment on this before we go forward?
I would like to do that, but I have no idea what this is.
Central retinal artery.
Can I come in here, Atul?
Yeah, please come on.
What about the external carotid artery embolus going into the retinal branches? Probably that's external carotid to the ophthalmic artery collateral. Could be one more thing.
Normally not. Normally not. That is when you have an occluded internal. Yes, then there are collaterals going up from the external. But in that case, I think the external was also not diseased. Yes, therefore I think it's not the external.
So you see, any embolus from here is likely to go not retrogradely, probably. Yeah.
Hi, Vipul, can I make a comment?
Yeah, please.
Yes, please.
Yeah, hi. Yeah, so what I see is that just after the procedure, your patient was fine.
Yes, this happened after 24 hours.
Yeah. So, yeah, I don't really think that this is a ophthalmic artery embolus because you are seeing the conjunctival congestion here.
Yes.
And the patient had, and the patient had hemicranial headache. So these are the two things which is slightly, not common with the simple ophthalmic artery embolus. Rather than it can be a feature of hyperperfusion.
Absolutely agree. And
yes, but he has also visual
other
loss,
thing is,
and visual loss is not connected with the external carotid artery.
and the other thing is, transient visual loss. I don't know how long it continued. Transient visual loss is well described in the literature just after a simple angiogram itself. So yeah, sometimes it can happen because of some sort of drug reaction or some sort of contrast reaction, but I really don't think this is like an ophthalmic artery embolus just because he had headache and severe conjunctival congestion.
absolutely. So, I absolutely agree there because of the integral circulation, we were very worried about hyperperfusion anyway. And this kind of starting with headache, severe headache ipsilaterally, is very indicative that maybe it is hyperperfusion what we are looking at. And I absolutely agree with that. And we got a scan done. And what you could see, there was very small subarachnoid hemorrhage as well. So to us, it indicated that probably what we are looking at is hyperperfusion here, and that fits in. And ophthalmology consultation, and what they found that the right eye intraocular pressure was extremely high. It was 60 millimeter as compared to left side of 20 millimeter. Now that was an unusual situation, what is happening here. And I will just go over, we always do our neuroanesthetist, always do preoperative transcranial Doppler in all of these patients. And what they had seen previously was that there was reversal of flow in the ophthalmic artery in this patient. Because of severe stenosis, there was reversal of flow. And there was an ocular ischemic syndrome. So I will just skip over some of the technical points. The ocular supply is through central retinal artery. And of course, then there are the ciliary arteries as well. And that is central retinal artery supplying the central area, and ciliary artery, the more peripheral areas. Now, what can be the ophthalmic artery dynamics in patients with intercalated artery stenosis? So of course, both of them may have antegrade flow in the IC and ophthalmic artery, or IC may have retrograde flow, ophthalmic artery may still have forward flow. Or like in our cases, the IC had antegrade flow, but the ophthalmic artery, there was reversal of flow. So there was underlying ocular ischemia in these cases. And when we studied in detail, there is a concept of watershed zone or water zone in the eye as well. And what happens is, because of this ischemia and hypoperfusion in the globe, that triggers synthesis of VEGF. Of course, we didn't know this. We did all of that, reading was quickly done when all of that happened. And because of that, there is proliferation of vessel in the eye, all right? And what happens is that the ocular, why the intraocular pressure is high? Because the aqueous formation and absorption, it happens at this angle. And because of vascular proliferation, the angle tends to get occluded. So that is why the aqueous which is getting formed will not get absorbed. And the sudden increase in perfusion of the eye, when we open up the artery in this patient, that lead to increased aqueous formation. So while a stable situation will be low aqueous production and low outflow, but in this case, when we did post-stenting, there was immediately very high aqueous production, low outflow, and extremely high intraocular pressure leading to sudden loss of vision. And that was the reason in this patient. And it was managed by mannitol, as we discussed with the ophthalmologist, and Diamox. Some analgesics were given. Daily ocular pressures were measured, and we continued mannitol till the intraocular pressure was less than 30 millimeter, and the blood pressure was strictly managed. And very thankfully, this patient made a complete recovery in this patient. So my take-home messages were, from this case, that flow reversal in an eye, that can be a surrogate for ocular ischemia. And in fact, if one is very careful, one wants to, and pre-op ophthalmic examination can reveal the signs of ischemia, vascular proliferation. And this kind of hyperperfusion is a very rare complication, can result in sudden aqueous production, intraocular pressure. Of course, one would always think about embolism, but that is why here the regular ophthalmic examination can catch that it's a rise in intraocular pressure causing the vision loss in this patient. And we have just published this case report as well in Neurology India. And I want to thank my team to make this case study.
So very interesting case, Vipul. Excellent.
Congratulations. Yes, it's a very rare complication.
Correct.
But don't you think this could just be acute glaucoma?
This was acute glaucoma, but triggered by stenting.
Or by atropine?
No, we never gave atropine. I mean, we don't give atropine as a routine. And so in this case, I mean, and we do so many carotid stents, we don't see that. So in this case, as I mentioned, the transcranial Doppler, there was reversal of flow, which was documented beforehand. There was neovascularity, you know, and I'm not presenting all of the ophthalmologic findings around here. And then sudden rise in ocular pressure.
So the neovascularization can happen within 24 hours. That is what.
No. It was pre-existing. So what happens is the neovascularization was pre-existing because he had chronic ocular ischemia. Okay, that will lead to partial angle closure anyway because supposedly it formed fibrosis in that area. All right, but that was being balanced by low aqueous production. When we open up the artery, okay, in this patient, there was sudden increase the reversal of flow in the ophthalmic artery. So sudden increased pressure in the globe, and that led to high production of aqueous. And because it couldn't get absorbed because of that endothelial proliferation anyway, it led to sudden glaucoma and vision loss. So that was the, of course, as I said, this is not something which I knew beforehand. We read and discussed with the ophthalmologist, and then that was the hypothesis which we have just published. Yeah.
What was the long-term outcome?
Sorry, your patient did well, thankfully. And I think we were very lucky. Rather than chasing thrombolysis, we got the ophthalmologist in and they saw that intraocular pressure was high, which we would have missed otherwise. Yeah.
So this patient was prone to develop glaucoma in future also, but
yes,
due to carotid stenting, he got an acute episode precipitated.
Yes, yes, of course. Because of chronic ischemia, there was, as I said, proliferation. So anyway, he was prone to it.
Excellent case. Thank you very much. Very, very interesting. Any comment? Otherwise, we are moving to our next presentation.
Just one question, sir.
Yeah, please, Omar.
I wanted to know what did Dr. Vipul, fantastic case. What did you do with the dual antiplatelets? Did you continue it because of that mild subarachnoid hemorrhage, or did you what did you do after that?
Frankly, this case was sometime back. Remember, I think we omitted for a day or so. This was very small amount, and you know, you omit for it, it doesn't matter. Patient still has antiplatelet effect. So by and large, we continued. Yeah, it's not that we stopped after 7 days. We didn't do that. Yeah, we got a
just one comment, Vipul.
Yeah, so Kalyan.
Yeah, here what I think this is not subarachnoid bleed. This is just a feature of hyperperfusion because what we see in hyperperfusion and because of a lot of contrast we give, you know, the gyral and sulcal hyperdensity in CT scan, and they usually go away in 24 hours.
Yeah, we have seen that in 2 cases of flow diverters now, particularly.
Absolutely.
We didn't give a lot of dye. We have seen after flow diverters, these kind of sulcal hyperdensity, if I may say, and which tend to disappear. And now nowadays we don't react too much. So yes, in looking back now after that, we have seen quite a few cases of flow diverter induced sulcal hyperdensity. I would agree with Sukalyan that maybe it was just congestion in that area rather than a frank subarachnoid hemorrhage. Yeah.
Excellent. So we move forward to the next case, Dr. R.D. Yadav. Interesting complication which has happened to a lot of us. And let's see what are the different ways of handling this. Dr. R.D. Yadav, over to you.
Good evening, sir. In front of masters, are you able to hear me now?
Yeah, very clearly, very clearly. Let's see your slides.
So in front of masters of carotid artery stenting from whom we learned in different meetings. So my case is simple carotid artery stenting where I found difficulty in retrieving the filter because of tortuosity. So this is 70-year-old male presented with recurrent TIA of right MCA territory. He was hypertensive, diabetic, underwent PCI with a stent of LCX and OM1, which was patent. Carotid duplex ultrasound showed 80% stenosis of right internal carotid artery in the bulb region. Was on aspirin and clopidogrel as well as 40 milligram of rosuvastatin. Echo showed normal LV systolic function. So this is stenosis which was not tight enough. Distally, the tortuosity was also not looking that great. So what I did, Yes. So what I did is put the, this is a bovine arch. So I spider filter, 7 millimeter. Then dilated with the balloon, 5 millimeter balloon. Put the your exact stand, and after exact stand was put, the artery was looking more tortuous, and the filter was distal to the tortuous region. So deployed the stand. Filter was slightly coming, so pushed it up. Then don't go high pressure. After the balloon dilatation, that I was not able to retrieve the spider filter by putting the blue end of that is the reverse end of the retrieval capture. It was not coming inside the retrieval seat. So what I have to do, I put a 125 centimeter multi-purpose 5 French catheter, because I have used your 7 French hook settle seat, and then took the filter inside this multi-purpose catheter and took out the filter. And as you see, this is a closed cell design stand where it gets the bend. This is 10 to 7 into 40 millimeter length exact stand. And so there is a bend because of the closed cell design. And intracranial, there was no problem, no complication at all in this patient. Intracranial is okay. Both your lateral view as well as Townes view, there is no problem in any of the branches of the right internal cavity intracranial vessels. So right ICA was stented by using spider filter, but because of distal ICA tortuosity, reverse part of the spider delivery system could not able to capture the filter. Therefore, 5 French multi-purpose catheter, 125 centimeter length, was used to retrieve the filter from tortuous region of the right ICA. No complication occurred, and it should be advised that the 300 centimeter of length of the spider wire should not be broken. If required, you can use as a long angio catheter or even guide catheter to retrieve the filter across the stent. And so, and long catheter can be used with a wider lumen to retrieve the filter if it doesn't come in the capture part. So, in the tortuous landing zone of the ICA, or you can make the monorail system of the angio catheter, and you can retrieve the filter.
That was an excellent salvage. A comment from Dr. Sriram Rajgopal, and then Klaus Matthias and Horst Sievert after that. Sriram, comments?
Yeah, innovative way to get out of difficult situation. So credit to Yadav as always.
Great. Horst, would you like to make a comment on this?
In this anatomy, we always, in all cases, we use proximal protection, and this avoids all these complications with the retrieval of distal filters.
But we don't have proximal protection at the present moment in India.
Yeah.
Device came but went away. I don't know why.
Okay.
Any more comments? Sriram Iyer and Gary Rubin?
Am I allowed
one thing to
comment, sir?
Yeah. So Sriram Iyer first, and then Ajay Swami. Yeah.
One thing to keep in mind in these kinds of tortuosity is simply rotating the neck.
Yes.
That will change the alignment of the carotid artery. And what was kinked in one view and in one direction, you just take it completely on the other side, and you may suddenly see that your carotid artery is now straightened.
Yes.
And that can help. So that's something.
I tried that technique, sir, because it is known from your lecture beforehand. Also, I have heard your lecture, and we were turning the neck on the other side, so it becomes straightened, but that didn't work.
Right. So the neck of the patient, not of the operator, correct?
Yes. Yes. Sasko, do you want to make a comment? Sasko, yeah.
So, additional option in this situation could be retrieval with a guide liner. So you can go with a guide liner on a short wire segment.
Yes.
Dr. Ajay Swami?
Yeah, just last point. I think all the other 2 points have been spoken of by Dr. Sriram and Dr. Sasko. Sometimes just manual compression will also help. If turning of the neck doesn't work, sometimes you can just press the internal carotid. It will straighten it and make it easier to retrieve. Everything else you have shown us very nicely, Dr. Yadav. That is, put in a catheter inside, turn to the other side, use a guide liner. People have used a balloon as well. I mean, I just reviewed it. I mean, and I've seen one presentation in which the filter got stuck in the stent. That was a really difficult situation, and the operators managed by inflating a balloon and just pushing it slightly distally, and then retrieving it inside a catheter like you did. In fact, he used a neurointerventional catheter to retrieve the filter within. And luckily, there wasn't much debris, but although he did take the precaution of aspirating from the filter before trying to do all these maneuvers, so that even if there was anything that broke off, it wouldn't really reach the distal circulation.
Dr. Ranjan Shetty, would you like to make a comment? Please unmute yourself. Yes.
I think I thoroughly enjoyed all the presentation, Dr. Mathur. Congrats for this. And this was a very good presentation. I like the point, typically we tend to break that wire and keep it, short when we use this filter. And after this, I was thinking we should actually preserve that 300 and we could to pass some other catheter. But guideliner is a very good idea because that's something which is always there in the lab and we could easily retrieve it with that.
Last words from Klaus Matthias and then Max Amor.
Yes, I can only add, yes, have enough distance between the distal end of the stent and the filter, so not too close. So you can better manipulate with whatever catheter you want later on. And what I also used routinely was already mentioned, turn the head to the side, yes, and stretch the artery. That is very helpful. Sometimes also when you not only want to retrieve the filter, but also with other things. So like placing the stent very precisely here. The stent was a little bit high up. It was not covering so well the common carotid artery, yes, and so that's perhaps also a reason why there was not enough space between the distal end of the stent and the filter. And therefore I mentioned go up with the filter, fire up close to the siphon area, then you have enough space for all the manipulations.
And the final word from Max Amor. And Shri wants to make another comment, right?
Go ahead, Max.
Yeah.
What has been said about rotation, if it works. One thing is not sometimes not rotation, is to push the chin against the sternum that way, and sometimes it's strafing the carotid and allow the retrieval. That's the first. Second point is that when that happens, is to use the same balloon that was used for post-dilatation, inflate it in the stent, and take that opportunity to push the guiding catheter or the introducer inside of the stent, putting it in close to the balloon, and usually it strengthens the stent and it allows the retrieval. Third point, if everything fails, is to use the old technique of placing a 0.35 balloon. Usually the 0.35 balloon allows the retrieval of the stent without any retrieval catheter. So if you push it far enough, you're usually able to really retrieve the filter. So this is the other solution that I'm bringing to your attention.
Shri Iyer? Yeah.
One other technical point to keep in mind, and my colleagues from Europe will probably know this better than we do, is the selection of a stent that has got segments of open cell on either side, and the middle part is a closed cell. So the part that is across your, yes, so the part that is across the stenosis gives you the benefit of closed cell, but the open cell design on either end of that closed cell conforms to that tortuosity, because part of the problem here was the whole thing was a closed cell, so it was sticking like an unbendable rod, and that was what was causing that iatrogenic kink, which was making it very difficult. So these are some things to keep in mind. Not all of these hardware will be available in every lab. In fact, even we don't
we have these hybrid stents in India.
You do?
Yeah.
Okay, yeah. So that is also something to keep in mind, where to Klaus's point, if you don't have a clearing zone and you have to go as close to the natural bend of the carotid as possible, this is one other option.
So, friends, we have had an excellent session today. It's been nearly 4 hours, and I would really thank you all that you have sat on your chairs. I've seen some of you been there right from the beginning, and that speaks highly of your stamina. Of course, nothing like what Horst Sievert has been doing for 5-6 hours long cases. But today has been a great learning from all of you, and so much of experience came together. And for the benefit of the audience, I can see a lot of people are still logged in, even though it's getting a little late in this country. I thank you all from my heart, and goodbye to you, and keep safe in this pandemic. And we hope to meet next time in person when we will discuss and learn from each other more. Thank you very much. Bye-bye.
Thank you. Thank you.
Thank you very much. Bye-bye.
Thank you, sir. Bye.
Hi. Bye, Omar. Riza, how are you? Good to see you, Riza.
Bye. बहुत अच्छा रहा. Very good.
Yeah, good. We really
Thank you,
enjoyed it.
Dr. Mathur.
Excellent. Well presented, Nishit. Very masterly. तुम्हें मिल गया पुराना CT reports, huh?
हाँ निकलवाया मोना से.
Excellent.
Sir, NC is looking masterly, absolutely.
Yeah, he's a master.
अभी उमर आपको एक तस्वीर भेजेगा मेरी प्रोफेसोरियल लुक की.
Chalo, bye, guys. We are still on. We are live. There are a lot of people on the other side.
Bye.
Bye.
Thank you.